Well, thanks to the Health Cell for the opportunity to come and tell our little story, and for all of you for being here tonight and supporting these endeavors. What great stories. So this story starts out about 100 years ago when blood was really first transfused successfully during World War I. And 100 years on, we're going back to something that we did in 1918. Not quite a 300-year history of San Antonio, only 100 years of transfusion, but we'll celebrate it anyway. And what the transfusion consisted of in that era was whole blood. You go to the blood bank, you donate a pint of blood, that pint of blood gets stored and administered to someone in need. And that's a pretty good plan of care for those patients that are bleeding to death. What you need to know about injury and injury mortality in this country is that there are about 190,000 deaths from injury in this nation every year. And the number one cause of death in that group is brain injury. We can't really do much about that in the year 2018. The second most common cause and the leading cause of preventable death in that group is hemorrhage. And so when patients bleed, they get to a point of low blood pressure and a severe shock state. Their life is in the balance. You only have about 5 liters of blood circulating in your system at any given time. You lose 2 of that, there's almost a coin toss as to whether or not you're going to survive that injury. So time is life, because the more time you spend before you get to definitive care in a hospital or get to transfusion, your risk of death goes up. We've got a lot of studies that help to prove that. Well, about 50 years ago, we got pretty smart about separating blood into its components, platelets and plasma and red cells, so that a specific individual who only needed platelets, for instance, would just get platelets. If they don't need red cells, why would we give them to them? But we literally threw the baby out with the bathwater when we did that and went exclusively to component treatment and forgot that an entire generation of physicians and nurses lost the knowledge of whole blood. Now keep in mind that tens of thousands of units of whole blood were administered in World War II, more than 10,000 in Vietnam, more than 10,000 in the current engagement in Afghanistan and Iraq and now Africa. So whole blood is the only way to get platelets in a combat zone in most of the places around the planet. Platelets only last about 5 days, so there's no way to draw them and get them to the soldiers or the injured combatants that need them. The answer is the walking blood bank that sits here. Well, that's not an FDA-approved process. That doesn't mean we didn't do it. We did what we needed to do to save lives. First time that I administered cold-stored whole blood to an injured combatant was in October of 2001. I had not been trained to do it because my teachers hadn't been trained to do it because there was no whole blood to use. Fortunately, I had with me the 1988 second U.S. revision of the NATO War Surgery Handbook that had that story in it from Vietnam of how to do it. And we did, out of necessity, because we were on a desert island and we took care of the casualties, the first 2 weeks worth of casualties in the war in Afghanistan. We came back home, talked about it a little bit, but there was no appetite for anyone wanting to do that. We learned a lot of things from the war and brought those with us back here. We learned a lot of things here in civilian care that we took to the combat zone. And it was a little meeting that happened in Norway. Andre Kapp from the ISR was there with us. Elizabeth Waltman from South Texas Blood and Tissue, the then executive director of the American Association of Blood Banks. And they heard this little story that we were telling about what we had done after I retired from the Air Force and left San Antonio, went up to the Mayo Clinic in Rochester. And we determined that the best substance to administer to patients would be cold-stored whole blood in the pre-hospital setting, because that's where the patient, giving the patient what they need, when they need it, where they need it, not following a traditional pathway of, well, when they get to the hospital, we'll give them transfusion. So our partners up there were very forward-thinking and progressive about this. We started using cold-stored whole blood about 2.5 years ago in Rochester. When I came to San Antonio, it was the same summer that I came back here, that we had that meeting in Norway. Elizabeth pulled me aside and said, "We got to talk." So December of last year, so 2016, December 2016, I met with the foundation board of the South Texas Blood and Tissue Center. And this kickoff event took place last Friday, so just a little more than a year after that first meeting, we kicked off a whole blood, cold stored O-positive whole blood program to put in the 18 helicopters that serve the land mass of 26,000 square miles in South Texas. That organization is called STRAC that runs that. There are 5 helicopter agencies, 18 hubs. Each of them are going to be carrying 2 units of cold stored O-positive whole blood. They're the only other place on the planet that I'm aware of that has cold stored O-positive blood that they administer to patients is in the hospital, is in Pittsburgh. They don't give it to women because there's a concern that they could have childbearing issues down the road. We've done all the research on this. It's very safe, and the numbers are very tiny, and that issue can be prevented in most cases. So it's the only place on the planet that you're going to get cold stored O-positive whole blood in 18 helicopters across the size of an area like that. Now, that study that we did here was done on our own trauma patients. The first, about 18 months worth of patients, 65 of them got their blood volume replaced 2 or more times due to injury. The death rate in that group, 76%. That's getting transfusion initiated when they arrive at the hospital. That's the problem that needed to be solved. And thanks to BioBridge and Qualtex and South Texas Blood and Tissue, our partners at the Army Blood Program, at the Institute of Surgical Research, at SAMC, at UT Health, at University Hospital. We're talking about thousands of patients invested in the care of injured patients, all coming into violent agreement that we couldn't do this fast enough. Today, blood went on the 3rd of the 18 helicopters. Seguin is up next for their hub. I also found out something today that I didn't know, which is that San Antonio Airlife began to carry red blood cells just this week as well, until their turn in the cycle to get O-positive cold stored whole blood comes around. So for our future endeavors, what we intend to do, and Elizabeth, I'm sorry, I'm going to say something I told everyone else not to tell you, is that I want to put cold stored O-positive whole blood in all the critical access trauma centers in South Texas, just as we have in the helicopters. And hopefully we'll get a little bit of research funding sent our way to help make some of that happen. We probably couldn't have started this program off if it weren't for the San Antonio Medical Foundation and a grant that they provided to us to initiate this project. A lot of really bright people have come together. We're going to study this for safety, efficacy, and in fact, because the donor pool of O-positive donors is so much greater than the O-negative donor pool, this is a literal game changer. The press releases from that kickoff event reached the National Board of the American Red Cross, who are exceedingly interested in us writing up why we chose to go the route that we went, because that would be a game changer for all these other places. I can tell you at Mayo Clinic, they can't maintain their supply of O-negative whole blood. It runs out too quickly. They don't have enough donors. And we're not going to exclude women like they have in Pittsburgh. That would be crazy. There's a lot of study to be done. You'll be hearing more about it. Again, thank you so much for your time and attention and for the opportunity to get up and present this work.